All right, so what I'm going to be doing is I'm going to set the scene, okay? Set the scene about what we've been doing in the past, and then, the other speakers will move on to what we will do in the future. So, not many disclosures, not as many as Professor Yaffe, as you'll see. So, as you know, the anatomy of an erection, it basically involves either sensory, auditory, visual stimulation, which then leads to increase of blood flow within the tunica epigynia, and that increase in pressure leads to closure of the sinusoids and erection. Very simple, this is basic physiology. At the cellular level, what we're looking at is the increase of nitric oxide-mediated responses, and that leads to changing or creation of psychogenic, which then allows the intracellular efflux, so it's calcium leaves the cell, and that leads to, again, smooth muscle relaxation, and hence an erection. So there are many, many causes, we know this, okay, about erectile dysfunction. Don't forget the psychogenic components as well. And these are all often interrelated and have implications in how we manage our patients. And therefore, we need to look at this from different areas in a holistic manner. So what I'll be covering today will be, firstly, lifestyle interventions, because don't forget, this is the perfect time to intervene in a man with cardiovascular morbidity, with erectile dysfunction. I'll also look at the PDE5 inhibitors, which really have been what underpin our current management of erectile dysfunction, intracavernosal injections, intraurethral treatments, and then also vacuum erection devices very briefly. So what about lifestyle interventions? Don't forget, lifestyle interventions have broader benefits than just treating the erectile dysfunction. And ED is a strong motivation to the man to really do something about his lifestyle, about his health, and try to improve his functionality and his functioning. Really, remember, it is all about shared decision making. You do need to engage with the man, understand his priorities, try to influence the priorities, and don't forget his partner as well. Looking at several factors, smoking, we know that smoke cessation will help to improve the erectile function of men. This is a systematic review, a bit old, but the results are very clear. If you stop smoking, your erectile function will improve. What about physical activity and exercise? Another systematic review looking at 7 studies, and they followed the men up to 2 years, and again, there was a clear benefit in prescribing physical activity and exercise in improving erectile function. We know lifestyle intervention works. In this RCT, looking at the interventional arm where they had a structured diet, exercise, and counseling program, there was a clear improvement compared to the control group who had standard therapy. All right, let's move on now. As you may recall from looking at the previous cartoon, we know that PDE5 inhibitors will stop the production of psychogenic. Therefore, by doing so, it increases the efflux of calcium ions and promotes an erection. Are they all the same? No. So when using PDE5 inhibitors, it's really important to understand the nuances of each of the medications. Sildenafil is the one that we use most commonly, especially in the NHS, because I'm told what I'm allowed to do. And the main thing with this is to know that the oral bioavailability can be significantly affected, and therefore, when prescribing this to men, we do need to really counsel them and teach them how to use the PDE5 inhibitors correctly. Sildenafil has a much longer half-life, but therefore takes a bit longer to reach a full Tmax. So again, you do need to include this in your counseling of the patients. Sildenafil, on the other hand, has much quicker onset of action. Again, what about the side effects? Because this will also influence how we use the medications in this group of population. For example, if a man says to you, I'm getting a lot of hot flushes from using sildenafil, then therefore consider using tadalafil, because that has a much lower incidence of facial flushing. Remember, tadalafil is the only medication that can cause myalgia, so don't forget that that is a risk, and therefore, if the man is complaining of myalgias, consider this as a potential adverse event. So important points when using PDE5 inhibitors: fasting instructions, especially for sildenafil and vardenafil. Don't forget, they do need to be aroused or have desire for these tablets to work, and therefore they should try the medication several times at least before giving up. It's not good enough to just try it once and then give up and move on to something else. Check the dosage of the man, because often the patients will have taken it at the wrong time, taken it in the wrong way, and I always go through detail with the patients to say, how did you take it, when did you take it, and et cetera, et cetera. Try at least 2 tablets, and don't forget the absolute contraindications of nitrate medications. All right, moving on. What about intracavernosal injections? This is the oldest and the most effective pharmacotherapy we have for erectile dysfunction. It is invasive, however, and because of that, more than half of men will cease using the injections over time, and therefore there's poor long-term compliance. Men have to be trained in using this appropriately, and that does take time, and therefore they need to have had the opportunity to meet with nurse specialists in order to use this medication. But the bonus is that because it works with the cyclic AMP pathway, they do not require desire or arousal. The injections will work regardless. What are the types of injections available? This is obviously different between different jurisdictions. Caverject or Riverdale or similar, which is aprostadil, comes in a self-injector and is therefore quite easy to use. I know in America and Australia, for example, Trimix is quite popular, and that's because it has a lower risk of pain. We have Invicorp, which is a combination of eryptadil and phentolamine, and this medication we use quite a lot in the UK as a salvage option, especially in men who have failed Caverject due to pain, and it works quite well in that particular population. So again, there are nuances to using the different types of medication, and as a sex med physician or a practitioner, we really do need to understand the nuances and have this within our armamentarium. What about the intraurethral pellets? Unfortunately, Muse has not been on the market, at least in Europe, for quite a while now. It's still obviously quoted and it's still within the guidelines, but the main point with Muse is that it has to be refrigerated. So bear that in mind, especially if the men are traveling, for example, or they're storing it at home. What is available is Vitaros. This is a gel, and if you administer it in the right way, and this study showed that if you administer this gel within the urethra, it has better efficacy. So you can use this, although it's a lower dose. They have a permeation enhancer within the medication, which helps the availability and the efficacy of this gel. I tend to use this more in patients who have issues with erectile dysfunction, with floppy glands after penile prosthesis, but it can be considered in some men, depending on their priorities, as a primary treatment for erectile dysfunction. And very lastly, just to touch on the vacuum erection devices, to be honest, many men do not enjoy using this because it's quite fiddly to use. It doesn't require them to keep things trimmed down below, gel, and so it's messy. And most of my patients, I must say, tend not to enjoy using this. However, it is reliable. It is a one-off cost, which is for some patients important, and it is non-invasive. So there are some groups of men who do enjoy this or use this in their day-to-day life. I tend to use this more for rehabilitation after cancer surgery, for example, or pelvic surgery. Efficacy of the vacuum erection device, if they do stick with using this, it can be quite efficacious, but as mentioned, the compliance over time can decrease. So what are my take-home messages? There are multiple treatments out there, so as a practitioner, we do need to understand these treatments and use them for the right man and for the right time. Lifestyle intervention is important, so do not forget this. PDE5 inhibitors are probably the first-line option, though, for most men because it's a tablet, it's easy to take, but it can be costly, especially if it's not funded by a socialized healthcare system. Each medication does have important differences, and don't forget, shared decision-making and involve the partner in everything that you do, if possible. Thank you.